Firstly, I just want to thank everyone for joining this call, where we're going to explore what Forest Close have been doing around physical health. Could I just start by asking you to all introduce yourselves?
Hello there. I am one of the higher trainees in the trust, one of the medics, and I've worked at Forest Close on and off for a few years.
Okay. Sharon and Anne-Marie, do you want to go next?
Okay, so hi, I'm Sharon Ashton. I'm a ward manager at Forest Close, currently on Ward 2 and Ward 3, and I'm also the physical health lead for the site.
Hi, I'm Anne-Marie Martin. I've just been made a Band 4 for Physical Health Lead Assistant, plus I'm a support worker, which I've been on Forest Close for the past 13 years, and also been running the Clozapine Clinic for that duration as well.
And Mandy, would you like to introduce yourself?
Yeah, my name's Mandy Reynolds. I'm an RGN and was brought in originally end of March, to help with the COVID patients that we may have got. So I've also been helping with the physical health as well since then.
Great. Well, thanks again for everyone joining me. I appreciate it's really busy on the wards at the minute. So I'm going to ask a few questions just to try and get your experiences on how this work's been really. So I was going to ask firstly, can you just give a bit of an overview of the changes you've introduced on Forest Close around physical health? So Mike, I wonder if you could.
Yeah, so I suppose this all started a few years ago with the change in rehab services in the city. We'd moved from having a ward and Forest Close as separate, with Forest Close being a longer stay unit, to more of a service where we're trying to get people turned around in set timeframes. This meant that there was a number of people that were leaving Forest Close and moving into the community that hadn't been done before, and it meant that there was more of a focus on physical health. People that were coming in were a little bit more acutely unwell, and we needed to work towards improving their physical health longer term. So I suppose patient population unit, we found that that we needed to do a little bit more work on physical health. We weren't as aware of the problems that people were having as we had been previously for those patients that had been with us for many years. And so we started dealing with that. I think some of the work on the physical health came from the Leicester tool, so the tool about monitoring people that are started on antipsychotics. And we started coming up with our own ways of monitoring people's physical health, making sure that we've got a good handle on things. We also noted some problems that weren't existing for other services. So we have our patients on Forest Close for a lot longer. 2+ years is generally the case. And we were having to think about things like screening for cervical cancer or breast screening or any other thing that would normally be done by a patient's GP, but we had to think about now because they were under our care for that length of time. And I suppose it was that focus that brought us to this work, and realizing actually we need to work a lot with these patient groups. They're often very affected by their mental health, and part of that is they don't look after their physical health as well as they could, and so there was a big need for us to do some work on this.
Great. Well, Sharon and Anne-Marie, can I just ask then, because obviously I've been involved in this and I'm aware of lots of changes which have happened. Could you just describe some of the changes that you've introduced?
Yeah, so from what Mike said, we developed a physical health clinic whereby we wanted to really concentrate on a person's whole, holistic physical health, the whole picture, and mental health as well. So that involved us setting up clinics where we got dedicated time to give to service users and quality time as well with a medic, with a member of the team, so we could go through the physical health checklist in detail. Then from that, we developed a plan using the Leicester tool, And from the plan, it was all service user led. And what we found was that the service users were really, really engaged and really eager to be involved in improving their physical health. So the tailored pack, we developed a tailored package for each service user and took it from there, and then referred, as Mike said, for either, you know, for screening to other, for example, creators.
Great. So it's because one thing that I've noticed and have been particularly impressed with is you've set up the clinic and then you do the follow-up clinic with somebody, but actually between those 2 points you've worked really hard to come up with interventions which could actually help people. So I'm casting my mind back to when I was involved, but things like walking groups and somebody went swimming.
We've got a lot of things what have been available with his staff as well, with support workers are getting involved with the physical health. So we've got the walking group what's still on, we've got the swimming now what's we've just took part in. I know it's a bit tricky with COVID, but it is manageable. We are doing it as long as it's a one-to-one, so it's a member of staff and the actual patient itself going for that. We've got the gym on lodge, which we are using more regularly now, but again, it's on a one-to-one basis due to COVID. We've got cycling group and like walking and running group. We've also incorporated making sure that we've got the aromatherapy still going as well, as much as we can. And also what's really been really useful is mindfulness, which I've been doing quite a lot on ward with patients as well. It's been really good. A lot of de-stressing techniques with using, obviously, you know, like the stress balls and things what they can actually use as well in the green rooms, which is really useful for them. And that obviously cooperates in with the clinic that I do, which is obviously all the physical health. It's the monitoring. We do obviously the weight, the BMI, all the OBS every 3 monthly. And then it goes down to your bloods, which are the clinic that I run. It's incorporated. It used to be the clozapine clinic, but now it's more the physical health and wellbeing clinic, and that cooperates obviously with all routine bloods as well as clozapine monitoring as well.
I think as well as what you've just said, Anne-Marie, I mean, we've got a pretty comprehensive list of interventions we can, you know, work with patients with. I think we also set up some groups, and again, it all needed to be patient-led. I think what we found out from the research that I looked at prior to setting this up was that service users felt that they had interventions done to them, and especially when the patients come into a secure units or lock units or anything like that, any sort of units that are quite restrictive on leave, patients find that they felt that the physical health had actually deteriorated once they were in hospital. So again, what I didn't want to do was impose interventions on patients. I wanted that to come from the service users. So we developed the wellbeing groups as well. Like I said, the agendas were all set by the service users every single time. Service users learned how to do basic life support, gain skills and qualifications in that, and also choking in association with the what do you call it? Patient council. So we to make sure that it was the kind of thing the service users enjoyed, and any changes we needed to make. And we also then set a group up so that the service users could choose what the next set of groups would be. So it was all service user led.
Yeah.
And just to build on that, because one of the things that I've been really impressed with the conversations that you've been having is a lot of the conversations were around motivation of service users, and how do you actually encourage behavioural change so that people get more engaged. And I think you've touched on that about service users being responsible for the physical health and well-being group, and it's really co-produced what came out of all of this work. So as a observer, it's just been a fascinating piece of work to see you progress. So that leads me on to the next question then. So obviously you've taken this forward largely through the microsystem. Can I ask what were your experience of that, and why did you decide to take it forward that way?
I think
In fact,
I want to start, I think, and then you're going to come in a bit, aren't you?
Yeah.
I think, Anne-Marie, because I think from when we first came to see you, Lee, we'd obviously been involved with Microsystems before, for Forest Close anyway. I was really impressed by the support and the help that you've given to the service through Microsystems. And I keep such a large project that we needed to really take control and focus and not be overwhelmed by the project, really. So I think Microsystems was really instrumental and supportive in the fact that it helps us look at areas we would have perhaps missed, and really drill down into the tiny details of how we progress and how we improve service users' health, really.
And we found in mental health services, obesity were quite great, and this is why we looked on obviously more on the physical side as well as the mental state, because obviously if they're unwell physically, the mental state's going to drop as well, and that kind of linked. And we did have a lot of obesity on site, so this is why we had to take it on board. To see to that, as well as just the mental state, and we have had a lot of good outcomes, really. To be fair, we've had good outcomes of since we've actually started physical health and well-being and looking at that. A lot of patients' mental state is actually improved without focusing on medication too much. Because a lot of them do focus on PRN, and we've tried to come out of that to look on the physical and health well-being to promote their mental state, which is been really good.
It's all interlinked.
Linked with everything.
Yeah.
Okay, great. Does anyone else want to add to?
Yeah, I was just going to talk about that as well. So this piece of work we did start outside of a microsystem approach. It was so myself, Sharon, and Anne-Marie started the work, and it was quite a medical focused piece of work at first. But actually, we realised that one of the things that we needed to do to continue to improve people's physical health was understand what we should be doing and what we are doing, and actually the assessment process, which is part of the microsystem approach, was very useful. So Sharon spent some time looking at all the different guidelines, figuring out what we should be doing based on each one of those. So we've talked about the LEST guideline, the NICE guideline, and various other information. So at the same time, we were going through the AIMS accreditation process, and tried to come together with
as well.
And tried to come together to determine where we should be, looked at where we were, and moved that way, because I think it was important to be able to measure the improvements that we were making, and make sure that what we are doing, we aren't making things worse. So I know one of the things that was picked up was that actually people's weight was increasing from admission to discharge, but actually it was important to make sure we had that information at the beginning, because if we measured this after interventions, we could think that actually we're making things worse, as opposed to actually that is the natural order, and we need to stop that from happening. And finally, I think it was important that we got lots of people involved. So towards the latter meetings of the microsystem, there must have been a good 15-20 people in a room when we were allowed to have such numbers. There was dietitians involved, physios, support workers, the clinical nurse manager, psychology, medics. Everyone was involved because everyone's got a part to play in it. And like you said, Sharon, as well, the service user involvement is always important. And all that is part of the mental health, the microsystem approach.
And I think I'll just pick up on that. Probably the best thing about being involved in coaching this work was just the sheer volume of people who were involved in the meetings and the diversity of views. And like Mike said, dietitian, physio, OT, support workers. There were a few meetings where we got service users involved as well. And I don't know, I think as a ward, you created some really impressive conditions where everybody felt involved to take this forward, and it was just a pleasure to be part of that, really. So shall we move on to thinking about, you've touched on some of the positives. Are there any more positives you just want to share about this work?
Sharon, we've been educated as well, you know, physical aren't used to. As well as taking over from Sharon and helping out with the physical health assessments as well with the clients.
Okay, great.
Which has been a really valuable piece of work, actually, Mandy. Yeah, I'm glad you've mentioned that, actually. I think for me, from a personal perspective, I'm very, very fortunate to be working at Forest Close. I've got a manager that helps me, that will actually support me to do various projects, take a lead on that. I've got wonderful staff like yourself working with different members of the team. Anne-Marie, I've worked with Anne-Marie for years, and we've worked closely with the phlebotomy clinic, the physical health clinic. That's something else that we didn't mention earlier, is that we've looked at all the blood tests required, again, against NICE guidance, physical health policy, AIMS accreditation. We've made sure that's all included and placed in a diary format to make sure that we're not missing out on physical health tests as well. So I'm very fortunate in that I work with a very, very motivated team in a lot of ways, and a very skilled team as well. So I think I needed to mention that.
Oh, absolutely. So can I touch on what have the challenges been in progressing this work?
The challenges, I think, is making sure that the staff are on board, really, to be fair. It's learning the staff and about physical health and what they can have their input as well with all the service users on each individual ward, because I mean all wards are obviously, we've got male and female and they're all separate, so it's just making sure that staff are on board with everything, which we are going there, and I think due to Microsystems as well, having that across that is actually made people aware of a lot of physical health problems, and it's not just about illnesses as well, it's about how much they're smoking, because we've actually incorporated smoking cessation, and staff's been trained for that, as well as myself, to obviously prescribe NRT. And that's really going ever so well, because obviously since COVID's been around, we've had to look on that more problem as an individual on each and every service user, and everybody's different. So again, it's about the physical health as well. It's on with smoking, because if they're on clozapine as well, if that's reduced, we have to look at all monitoring of clozapine as well. So it's actually been a good insight for across site, as well as I tend to up on lodge as well, which is they're on board with us as well, which is good, which is really good.
And I think what to pick up on what you've just said as well, Anne-Marie, I think getting it was a wider staff team, and getting those those people involved in the physical health as well has been quite problematic, as probably so at some point staff have thought, oh, it's the physical health team that should be dealing with it, we'll leave it to them. Well, actually no, it's everybody's responsibility. Yes. Everybody should be involved in that. So that has been an ongoing piece of work that we're having to sort of carry on working with.
Okay. So
I just wanted to add as well, I don't think it wasn't a challenge. But one of the things that we have found is that the first solution we came up with wasn't always the best, and actually realizing that going around that plan, do, study, act cycle was important, because we aren't going to get to the right answer immediately, and realizing that that's not a failure, that's part of the process.
Yeah, that's a good point.
Thank you. So just my final question then. So I like to hear from everybody really on this one. So what's next for physical health on Forest Close? What does the future hold? So
something about that.
So obviously COVID and sort of stops everything really. We were really working at some speed and improving the service. Mike had some ideas around us publishing the piece of work that we'd done. So we're going to take that. I think that's something I'm really keen to do. I've actually been given, I'm working part-time on Ward 2, so I've now got a day or two a week to actually concentrate on physical health again. So I think that's something that we'll be taking forward. Audit, we did do an initial audit with working with Phil. Again, we need to re-audit to see, if the interventions we've come up with have actually had the desired effect, and then look at what we can do to change that if it hasn't. And just sort of pick ourselves up from post-COVID Forest Close. I think carry on and not lose momentum of the work really, because that'd be a real shame to do that. Yeah. We need to carry on, and we've got, I've got, like I said, some motivated staff here. Yeah. And I'll be overseeing that, I think.
Yeah. And we also said about it's important for us, our students really, to get on board, because they are our future, and if we can promote this now to them, hopefully they can carry on this, because it's important for our mental health services really, and the physical health. So they are our future, and hopefully if we can pass things and training on to them, what we've achieved, that I think that'll be a way forward as well.
Okay. Mandy, can I come to you and ask what you're for the future around physical health on Forest Close?
Yeah, I mean, I've only been here since end of March, and it's all new to me here, so I'm usually a general nurse. But I've noticed it's a fantastic team, which is a good start. I just think it's just like I'm dealing with COVID as well. If we get a second wave of patients, so I'm here for that. But I'm also learning about the physical health needs and motivation, massive thing. If we can get staff motivated, which they are doing, that helps. I'm sort of concentrating on diet a bit at the minute, because getting a lot of patients to eat leafy green veg and healthy things, that's an ongoing issue we have, isn't it? But we're doing well, and we just have to personalise it to each client really, and get all the staff supporting that client as well. So that's what we're doing at the minute.
Yeah.
Okay. And then lastly, Mike, have you got anything you'd like to add?
I suppose so. I'm not working at Forest Close at the moment, but like Sharon said, we need to get back up and running and keep going. I don't think we're ever going to get to the point where we can rest back and think that physical health is solved. There's always going to be something extra that we can do, and in terms of the quality improvement ethos, there's always small improvements that can be made. And again, like Sharon was saying, it's about sharing that learning as well. So sharing both within the organisation, sharing what has worked well for us and what can work on other units in the organisation. They obviously have slightly different patient groups, so not all of it will be the same. But there's also sharing within the AIMS accreditation network that can go on, and like Sharon said, possibly writing something up and creating some kind of package that this is what you should do if you want to set up the same thing.
Okay, great. Well, that's my question. I'll just give anyone an opportunity if there's anything else you wish you'd said and you haven't already.
I think what I forgot to mention earlier on is around insight. Now I know we're getting that was another driving factor for actually setting the physical health paper, the assessment up, was that we've got various pieces of physical health monitored in various different locations on Insight. That is a real problem, trying to pull it together, and that's what we wanted to do, was actually pull that information together so it's not lost, basically. So it's important to have, and I know that they're working on Insight at the moment to improve that. And again, it needs to be in one area, so you can the CQC can access it, we can access it, and it's readily available to refer to.
Great. Well, thank you, and thank you all for spending the time to answer some of these questions. I think it's really important that people get to hear some really positive stories and improvements that are happening around the trust. And I've personally been inspired by the work that you've done, and I look forward to being able to come to the ward and get involved again.
Look forward to seeing you again as well.
Thank you.
Thank you.
Thanks, everyone. I'll see you all soon.
Thank you.